going to invite Dr. Mathonsi back to the stage. He's going to discuss management of our normal service and cancer screening center. Dr. Mathonsi.
We've been talking about the cervical cancer screening and HPV. The question now, how to manage it? And then we're going to look at how to manage it in the low resource areas via pap smear and also bring something new to our attention. As you know that 80% of cervical cancer occur in the countries. You know that? And of those, 2/3 are diagnosed in an advanced stage with a poor prognosis. And why? Mainly because of what we're talking about. Lack of organized screening program in a different. That's the reason why we are here. And if you look at the accuracy of testing in a developing country of these 4 methods, is different from the one that you get in a developed country. This was done in India. And you can see the sensitivity and the specificity. And then what become fascinating here is the VIA. And then why we know that the ideal screening in a low resource country, it must be low, it must have a good sensitivity, it must be affordable, it must be feasible, and maximum coverage. And tell you the truth, VIA meet those requirements. And then when we look at the visual inspection method, which was first used, introduced in 1930 by Schiller, well, with its poor specificity in the developed country or in the other areas, it was almost entirely made redundant by the cervical cytology, which is not good. Currently, screening protocol typically include the combination of cervical cytology and HPV testing. Visual inspection of the cervix has re-emerged in a low resource setting. It has re-emerged. So we must not underestimate what Dr. Nisi was talking about. Despite all its specificity, but if you look at the economically and the fact that it provides immediate results, it becomes something very easy for our countries. And that can be performed in the means either we can do a VIA or VIA or VILI. What would be the indication for this patient? It's for any woman whose cervical screening is indicated. And the best method of a screening, which one? We'll talk about the 4th one. Patients who do not have an access to cervical cytology, HPV testing, they must be the one who must be screened through a VILI and VIA. Those who do not have access. Is there any contraindication to those methods? So let you know. See, this is a good this is a good test. It might not be that ideal, but for the city, it's a good test. It hardly has any contraindication. And you can see VIA rather than VILI should be performed in the patient with an allergy to iodine. Can be performed even during pregnancy. Cervical biopsy are relatively contraindicated in a pregnant person unless this is suspected in an infection. Yes, acute infection preferably be treated before you do your inspection because inflammation and infection can impair your accuracy of your assessment. But even though it does not interfere much with your evaluation, so the fact that patient might have some little bit of vaginitis does not mean you need to bring that patient back. You still have an opportunity. You can still evaluate that patient, give the result, and act if it's possible. Is it effective? The two have a more likely efficiency, similar efficiency in detecting the CIN and as well as cervical cancer. VIA allows more nuance and a detailed examination of the cervix and is preferable to bleeding. Why? Because it allows some appreciation of the density of the acetyl whitening in the culture, as well as no abnormal vessel change that we look. Even if you do not have the colposcopy, you don't need a detailed colposcopy, which is something that we just can just talk about only in our limited resource country. Okay, is it something you need any specific specialized equipment, procedure, how is it performed? You don't need money. You just need either extract the patient or make simple thing. If you cannot have that table, the patient in a frog-like position, that can do. What more do you need? Speculum is readily available. Light source, something that can be used repeatedly, better lifespan. It's no big problem with this. Acetic acid chip, everything here is possible. There's nothing that limits us from performing these visual inspection methods. What do? You perform through the naked eye. It's not expensive. You already have those sort of resources. Your naked eye is available. Position, it's easy. Frog-like position. You don't need even the smart bed and all these with the legs. Insert your speculum, you visualize vagina, cervix, inspect the entire lesion. You ensure that everything is visualized, especially your squamous columnar junction that is completely visible. You apply one of your either acetic acid or ligocyanidine using a swab, inspect again after a certain minute, and you just look at the cervix. You get the changes. The only thing that can cost you is probably additional eyes for those who don't see well. Little bit of glasses. And you need to document the findings. That's all you need. And how do you interpret these results of a visual inspection with acetic acid? You can either have a VIA negative or normal, or you can have a VIA positive or suspicion of invasion. Okay, what is a VIA negative or normal? It's when there is no acetyl white or transparent lesion or faint painted lesion without a definitive margin. Or you have those lesions which are far away from squamous columnar junction, or faint lesion, not a dense lesion, a very faint lesion of acetyl white areas. A strip-like lesion like here, this is a strip-like lesion, and faint one, far away. Or you have this line-like acetyl white at the brim of endocervix, or you have some spot-like, dot-like in those pale areas. This is regarded as a negative or normal VIA. And positive one, listen, it's characterized by compressed, dense, well-defined acetyl areas. Dense, well-defined. At which area is formed of the columnar junction, and sometimes could be close to the external os or around the presence of the lesion, around the presence of the lesion. You look at this. Is this lesion dense? Yes, dense. Is it well defined? It's well defined. You can see this is a geographical mapping of a low-grade cell with the easy regular end, and you can extend to the posterior cervical portion there. High-grade cell, yes. Does you see a dense, well-defined, with some like a vascular changes there, the punctuation there is a vascular change that you can see with this method. So you can either have either it can be negative, be positive, and it could also be suspicious. You see again here, dense lesion, acetyl white. For those who have features suggestive of malignancy, it's usually a lesion that involves 3 or more quadrants, it usually extends into the endocervical canal or vaginal wall, bleed easily, and you have a raised, irregular lesion, often, with discoloration. This is more typical and more suspicious of malignancy. Definitely, a biopsy should be done in this. What about villi? Villi, again, you can look at here. This absorption of iodine by the normal cell here. You can see the pinhole, not much, normal. You can see the endocervix there. Little bit, there's not much here, but if you look at the positive one, it's next to the endocervical cell, next to the scalp. It's either there and extend throughout, but it's always involving the endocervix. That's a positive, and you can give you more of which is discoloration. And again, not so much. It's binary. Any complication with this test, this method? There are no complications except for those who have just a little bit of pain. Not that much. And again, if you perform biopsy, you might expect a little bit of a bleeding. Infection is rare, very, very, very rare. Is the method. What about the abnormal findings? What about the positive findings? What about the suspicion of the epicorrelation? What do you do? Area of abnormality, grossly lesion should always be biopsy. It should be followed by biopsy. The same thing, even those who have developed countries with colposcopy. A colposcopy alone is sufficient. It must be followed by biopsy. So we must do the same thing. An abnormal lesion must be followed by biopsy. In most settings, in the setting where the treatment is immediately follows, see and treat approach. Yes, you can do the same thing. See the patient abnormalities, immediately you have screened the patient, you have treated the patient at the same time. Biopsy should be taken from the inferior to avoid bleeding and the other target site. And of course, it's not really contraindicated to some of the other patients with bleeding disorders. Okay, let's move now. What about cytology and HPV? The management of this abnormality. Is there a place for this cytology and HPV? This is the first classification where they classify the abnormal cytology. The squamous lesion, which you know the squamous glandular lesion and other, it's fine, we know that. And the incidence of this, you have seen that HPV is very, very common, you see, but the risk of these things is very, very low. But majority of them will have cancer. We talk about that point, we think about 1.5% from 200 million population. And the different guideline or organization trying to look at what is the best guideline that we can use. The most important thing to note with this one is most guidelines, they initially started at the age of 21, initiation of screening with either cytology or HPV. You see here, the exit here is 65. This is a study that we get in a well-developed country. You have seen our exit here, we're talking about 70, 74. And with us, with that HPV in Africa, which remains persistent high, probably we should not exit, we should not follow this. This is something non-African. We should not follow, we can just look at it, but we should just have develop our own guidelines. Again, very important to note with this one, where between the age of 21 and 25, they usually use a pap smear cytology. Why? Because the risk of HPV is very common. Either way, they're going to pick it up. What are they going to do about it? If they pick it up, so there's no need for you. So that's why most of the time they start HPV from the age of 18. But currently there's a shift from the age of 21 to the age of 25. That's the consensus now. That's you are screening more at the age of 25 rather than 8. Because then you're going to find abnormal lesion, you're going to because of HPV, or maybe there's already some cytological changes from the cervix. And again, those who have removed their uterus for non-HPV related, can say it's not in the pap smear or HPV is not related. It's not indicated. And for those who are vaccinated, you still follow the same. schedule of Australia. This is the game changer. I don't know how many of you have looked at this paper, but this is a game changer to me. Now, we have changed. Now we're looking at the risk estimate, the risk-based management. We're no longer looking at, okay, you have HPV, you have high risk. Now, what are the risks of you developing? This is a game changer to me. And this is a very important thing. And this study was done for about 14 years in USA. And then they look at the risk-based management. And then looking at the intervention, you can either treat the patient, you can either give a optimal treatment or biopsy, or colposcopy biopsy, or colposcopy biopsy alone, or you can look at a surveillance of the patient, either 1 year, 3 years, or 5 years. This, to me, is a game changer. And the main thing here is what are the risks of you having a CIN 3+. CIN 3+. That is a very important. And what is your immediate risk and your 5-year risk of developing the CIN 3+? Look at the risk estimate. Yes, as I said, it was this paper started writing in 2019 with the collaboration of a very big multiple involvement in different countries, multiple organizations, the government, and that was after an intensive study which had 1.5 million of patients that were sampled with both cytology and HPV. And then they came up with the risk estimate management guidelines. And this is, to me, as I say, it's a game changer. It's published to change our management from now on. Look at what are the consensus recommendations and what are they based on? And they're based on that cervical cancer screening have shifted, not to us, to them. They've shifted from a primary cytology to primary HPV. Still not there, still too far. And again, HPV is more sensitive test for prediction for a payment compared to cytology, which can tell you what you are risk. It has nothing to do what is your predictive feature risk of developing a cervical cancer. See, the shift is based on that HPV, and also looking mainly on the oncological side, which are excellent marker for prediction of the present and the future risk of developing CIN. And mainly, not just CIN, but CIN 3+. That's the main. The rationale behind that risk estimate and the risk-based management was also the fact that the management decision of this patient with abnormal are based on the patient risk of developing CIN 3+, which is what? Which is CIN 3, adenocarcinoma in situ and cancer. Not the risk of you having a CIN 2, which can regress. Not just the risk of you having some abnormal in cytology, we just talk about the current status, but the risk of you developing CIN+. And with this risk, it helps us that you tend not to over-treat this patient or over-test this patient, because now it's directed more on the most severe abnormality rather than just the cytological changes. The risk of the CIN 3+. Compared with the CIN 2, there was not much different. And then the risk of developing CIN 3+ was determined by the presence of HPV and cytology results. Your drilling the results and your past history, whether you have a lens, whether you have whatever previously, that's where you calculate this risk. And then the patient is stratified as whether she have an immediate risk of developing the CIN3 plus? Or does she have a 5-year risk of developing that? That is calculated. That could be gathered the line, the different way website calculating, just putting all those lists together on that paper that I've shown you. They show you how you calculate that. And the risk estimate, it used the combination. That was the core testing that is being done as well as the prior history and condition of that patient. That's the risk, how you calculate the risk. This is risk estimate based management. It's a game changer in a developing country. And if you look again, say they need the what? The study was involving the cytology as well as the HPV code testing, looking at the previous HPV, not as a cytology result, HPV, and the history of them can be treated or not. Look at the origin of this. Where does it come from? This risk estimates. As I mentioned to you, the study was about 1.5 patient, which was done between the age of 25 and 65. Between the age of 25 and 65, which is what I said that now we're starting at the screening initiation of the screening at the age of 25. The patient was screened with they were screened with cord testing, the size of population as described, and they also consider some other similar trial which show more or less the similar result. They talk about there was this principle of equal management for equal risk, which has been already there in existence. But in this principle, what does it mean? It means that the same current screening result may lead to different management recommendation for one patient versus another, depending on the past in this case. Meaning that you can have a normal cytology for testing that you do, but if you have and someone have a normal cytology, but if one of them have a previous history of HPV, the management is not the same. This estimation is different. And that's where you need to manage based on the risk, not just based on the cytology that what's happening. The risk estimate need to be covered. The management must be based, even if you might have the similar result, but with the previous history or previous clinical management, whether you were done colposcopy, you were done the lip procedure, the risk estimate might completely change. And again, the most important thing is the past HPV that modify the risk estimate, that modify the risk of you developing, rather than cytology, which does not give you any prediction about the future development of this. It just tells you that's why you can use it as a reflex or as a reflex test in terms of a positive HPV. Look at this diagram. You look at it. The patient is being done. You do cytology. They do cord testing, which is the cytology and HPV DNA. Is there immediate CIN3 plus the risk greater than 4? Not. And if the answer is yes, then they look at this. If after you have done your cytology, your HPV, and look at the previous history, if they have the history of being screened before, if their risk is more of developing CIN3 plus, it's more than 4%, then you look at it. Then this patient needs a correct management. This patient, you need to find a correct management, which means which you are those. You can either do expedite treatment, which is it's mainly the lip or leg procedure, or you can either do colposcopy or a leg procedure. Those that depending on the risk estimates. You can see those who have a risk estimate between 60 and 100, they have a leg procedure. Those who have a risk estimate between 25 and 59, they have either can be treated with the leg procedure or else can be treated with the colposcopy. And those who are there, you're going to have colposcopy. And again, if the risk estimate is less than 4%, then you look at the surveillance interval. Should we follow up this patient every 1 year? Should we follow up this patient every 3 years or 5 years? That's what, depending on their risk estimate of developing that cancer in 5 years. Now, it's not an immediate, that now in 5 years. Then that's how it will be followed. And then the intervention there, it differs. For those who have a more than 60% risk, like I said, which are those patients who have a patient risk estimates of more than 60 patients. You can see here the patient who have a high grade cells who are HPV 16 positive. Their risk estimate is almost 6 of developing CIN3 plus is 60%. Those who have been unscreened, this patient, meaning that they're not screened in the last 5 years with a high risk HPV, with a high grade C and HPV positive, their risk estimate is also very high. This patient must be treated with the excisional procedure. And even those who have difficult follow-up, and what are the treatment options? Excision, colposcopy is unlikely to change any management, and ablation is not an ideal treatment. What about those who have a risk estimate? Between, we say this one can be treated either with the excisional procedure or colposcopy. Who are those patients? Are patients who have unknown, they've never been screened before in the last 5 minutes, but they have a positive HPV plus IRC, or positive HPV with a typical squamous cell that cannot exclude high grade, or those with HPV negative or with an previous HPV negative with high grade C. You can see their risk estimate with this patient that is high. Those who can be treated other. Those who have a risk, and you can see in this individual here, there's no contraindication. The only contraindication are those less than 25 years. Remember now the screening starts from 25 years. Pregnant patients, patient planning for this, that's what you need to consider, their future pregnancy. Colposcopy, if you look at for those with a risk estimate between 4 and 7, again, they don't need colposcopy. And those are patients who have a HPV with atypical squamous cell with ascus. And this one, HPV, no grade. You see the risk estimate now, it goes down. HPV 16 or 18, but never 5.5. Those are the patients that are HPV positive, but normal cytology. HPV positive, but no cellulitis. HPV negative, they have low C and no history of the previous. Those can be followed up in a year. Don't have matter. Did not really meet the threshold to colposcopy for this patient. Those who have a risk between 0.5 to 15, again, you can see those are the risk estimate. If you look at that, it's lower than what is between this. And again, HPV negative, ascus, no previous history, negative, ascus, prior, negative pap smear. You follow up in 3 months. Lastly, those who have, you can see this is typically a normal patient. Negative HPV negative cytologies not performed. It's only primary screening only. But those who have HPV negative and normal, that's right. They reflect just a general population of a normal cytology. Those their risk estimate is very low. You just continue as normal, like screening in 5 years, rather than doing 3 years. You can properly manage your patient based on the risk of them developing a CIN3 plus. For those, what about, we say this guideline does not necessarily talk about those who are less than 25 years. We talk about those who are more than 25 years. Less than 25 years, very easy. See, less than 25, just repeat, or you do a reflex HPV testing. This you repeat until you have multiple repetition of low seal. Then in 3 times, then you can do colposcopy. But here you repeat and you do a reflex test and HPV is negative, you just follow up returning. But those who come already less than 25 with this, you need to consider doing colposcopy and biopsy.